So we welcome you all today. And the program for today, we're going to have the session in neurology and pharmacology, chaired by Dr. Zing Wang, and co-chaired by, I hope I could get that right. You're going to help me there? All right. That doesn't mean that my name is easy to pronounce, you know what I mean? Mine is worse than yours. But let me see if I can do it right. Chitambia Benjamin. All right. Please, the co-chair. And then we'll have two presenters. They're not going to be here today, so this is going to be a short session. So we're going to have the first two presentations, and then we're going to have a break, and then we're going to come back for one more presentation. In the break, we're all going to go visit the poster session. There are 9 presentations in there, and then we're going to award the best poster presentation after the end of next session. Okay. So with this being said, I would like to turn over the podium to our chair, Dr. Sorry about that. Our chair, Dr. Zin Wang. Dr. Zin Wang.
Hi, good morning, everybody. Yeah, thanks for coming to this meeting. So today I'm the chair. So first of all, I try to introduce Dr. Hamid Gubenzi. Dr. Hamid, he is a professor at University of Mississippi Medical Center from United States, and he already have like many years experience, let's say 26 years experience, and have 250 publications, also have 600 abstracts at different meetings, conference. And he serves as the chairman for Department of Health Science Center. Also have is like a chair of Cetal Technology, and currently he serves as the chair of Department of Diagnostics and Clinical Health Science. Today his topic will be focused reproductive hormone using different animal models. Also, I see your name also like here, also linked with University of Michigan, so boss. Okay, go ahead. Yeah.
Thank you, Dr. Wang. Appreciate that. I don't know if some of you were here yesterday, but we talked yesterday about the overall view about the ceramic drug delivery systems and what we accomplished so far in this area. And today I would like to present before you one of the challenges we faced in dealing with the drug delivery system, which is the dual release attempt for the ceramic material. And with this, let me see here if there you go. We used sheep. We used the sheep model, which is comparable to a human in terms of size, and also most of the physiological parameters in a sheep fits, you know what I mean, and to be a good model close to clinical trials. So with this, like I said, we were challenged. We were challenged about the delivery profile to develop a new technology in which can do more just a release of one drug. So we developed the capsule in which can do multi-layered and also will induce one of the major physiological function. And in here again, we're selecting the reproductive hormones for our applications. And what we attempted to do, try to develop a four-layer capsule, in which is the first layer will release estrogen at sustained levels for like about a week. And then our goal is to see if we could have a burst effect in the second layer within the same capsule. And then we, in the same token in there, in the third layer, we'll have a combination of estrogen and progesterone. And then in the fourth layer, where we'd have a progesterone. So all of this is just to mimic the estrus or the menstrual cycle. Very complex, but we managed at the end to develop the capsule. From our experience before, to assess the effectiveness of the ceramic delivery system, this is a release profile in using castrated rams to see the feasibility of the ceramic capsule. They could release testosterone. And as you see in there, just from a trial in here, developing a tiny capsule, you just implant it in the axillary region under the skin, and you will see the, let me see, the, do you have, well, I could use, I guess, no, I could use this, and see the pointer in here. And he's busy, I think he's listening to music there. All right, okay. Anyway, so this is the castrated rams. This is the blood levels of testosterone level. You see it in castration. They don't have testes, so it's almost undetectable, the level of testosterone. And these are castrated rams. Castrated rams, they have the capsule in it. You see the sustained level. We managed to maintain a sustained levels. Is it there? He said it's here? Oh, I'm sorry. Thank you, Lamar. Appreciate it. Okay, so this is showing. You see that this is what the doing of the ceramic capsule. Release that profile in here. If you want to mimic that in injection, you can't do that. If you inject it here, you're gonna have a burst like this in circulation, and then goes down to zero. And then you need to inject in here. You can't inject every 10 minutes to achieve this. So to get that profile in here, you need to inject like by conventional means. You need to inject every 10 minutes for 60 days, 24 hours a day, to get that sustained levels. So with this, you see the physiological factor in here. The impact of it is you have to sustain the level to get to achieve the secondary sexual characteristics, like all the need for the steroid hormones. So with this, then we looked into, we said, is this the real testosterone? And so we looked into the hypothalamic and pituitary hormones. So from there, we looked into the GnRH, levels, and also we looked into the FSH and LH levels. So this is what we did. We gave, testosterone, and in some experiment we did DHT, dihydrotestosterone. This is the more potent hormone, and that implanted subcutaneously. And then what we wanted to see, a suppression of the LH and FSH. If, as you know, in castrated rams, the testes are gone, so the LH, FSH, and GnRH always high. In another way, the hypothalamus and the pituitary is highly overreactive. In another way, the chromophores in here, they will be like in castration or in postmenopausal stage, always they are hyperactive. In another way, they are busy in secreting more GnRH, more LH and FSH, due to the fact that there is no testes in there. So in postmenopausal women, you will see the high rise in gonadotropins, and in the same token, you see that in males. All right. Now, this is just showing you the negative feedback mechanism in here. And this is what I'm trying to say here in ovaries. Now, in ovaries, the same thing. They are the same hormones. It's always a challenging question to the students. Always they say, well, in males, they have LH and FSH, luteinizing hormones and follicle-stimulating hormones. And in a female, they got the same hormones. And I ask the students, say, well, why males, they have luteinizing hormone? We don't luteinize, we don't have follicles. But we go to clinical side, they say, well, that comes in from a physician and say, well, I need you to measure Benghuzzi's LH and FSH. All right? So we have LH and FSH. So we always ask the challenge the students, say, why we have LH and FSH? Why? Because the reason why, it's the same molecule, it's the same sequence of polypeptides. It was discovered first in females when they isolated, purified it in males. It's the same sequence of amino acids. So from there, they said there is no need for changing it. So we'll just leave it LH and FSH. But it's always funny, especially in the clinical setting, I said, what they found? Well, they found the so-and-so's follicle stimulating hormone is low. That got, hypogonadal condition. And it's, by stating it, say, the follicle stimulating hormone is low, it's funny by itself because they don't have follicles. But anyway. So look at it here. Like I said, that was for 2 months. I just showed you earlier. We went beyond that. In case of females, we used ewes in here, corianders, sheep strain, and we delivered here estradiol. Estradiol is not in nanograms. We have to achieve it in a very, very low level in picograms. And as you see in here, this is the non-breeding season. As you see here is almost zero, undetectable. And you see the estrogen presence that we were able to release it for up to 200 days. Okay, and then we looked into the in vitro profile in here to correlate the release profile. So this is a cumulative testosterone release in milligrams and in in vitro setting to assess, the layers, we're going to develop later. Again, here, the DHT benzoate profiles. And then we looked into the LH and FSH. You see that? So what you're seeing in here, the opposite. When you look at the pituitary hormones, we said due to the fact that there are no testes in there, right? So the LH FSH is supposed to be high, and that's what we're measuring in here. This is like in a pulse. You're talking about maybe 3 hours. So this is bleeding the sheep every 15 minutes. Okay? We took blood every 15 minutes to get at least one pulse, which is like about a 3 hour. So we won't miss any peak in there. So this is showing the significant rise in castrated rams, as you see that. The level of LH is approximately close, to 45, 50 nanograms per mil. And this is the doing of the tricalcium phosphate loaded ceramics. You see that? Suppressed the LH or the pituitary hormone to almost like undetectable levels. That's showing whatever we released is real stuff. Because this is always a question when we say, for example, when we deliver growth factor to stimulate bone and growth, people, they'll say, what makes you believe that this is a real growth factor? So we look at the assessment, we do morphometric analysis of the osteoblastic activity to see there is an effect in there. Now, the same thing, the question is, okay, we see it. You gave it to the animals. It's sustained levels. What makes us that would induce any physiological parameter? Does it interact with the brain? Yeah, the answer is yes, as you see in here. All right. Now, again, this is showing you the testosterone window, and the same token correlates with the LH. FSH, the same thing. With FSH, you will see, of course, the level is way higher in FSH. Ranges between 400, 500, 600 nanograms per mil. And you see that the level of FSH is extremely high in here. And compare it to the capsules, what released from the capsule, which is in here, completely suppressed. So really effective, whatever released from the capsule really affected the brain area. Now, again, we looked into the stress conditions in there, and we looked into the cortisol levels. These are the 3 sample of 3 sheep in the same group. We looked into the release of cortisol levels, and we see that it's sustained, the level of cortisol levels in here. Now, again, for TCPL treated animals, the cortisol level went down compared to the control group in the previous 3 sheep. So we used the 3 in here. And you see the consistency and the less degree of variability in here in the release profile of cortisols. Now, so this is a long-term release of testosterone in conjunction with tocopherol acetate. What we've seen when we gave testosterone for just to resolve a problem of hypogonadal conditions, what we've seen in there, we've seen that there was an increase in oxidative radical mediators. So we saw some signs of enlargement of the prostate. We saw some signs of the induction of shift in the myocardium. We've seen, with high dose of testosterone, we saw signs of myocardial necrosis in the muscle because it's a male hormone. It's like the athletes they take. So from there we said, well, maybe we need to add an antioxidant with testosterone to try to chelate the free radical species. So our first attempt in there, we added vitamin E with the capsule to be released in conjunction. So you will induce physiological, response, and in the same token, you try to chelate the byproducts, which is oxygen-free radicals. We did a complete study in there, looked at the lipoprotein profiles. We looked at LDL, we looked at HDL, VLDL. We looked at all of these parameters in there, and we found that oxidative LDL is induced due to testosterone level. So from our study from that, when that was published like about 3 years ago, were the first to report that what causes the cardiovascular damage, it's not the high LDL, it's not the total cholesterol. We said you could eat cholesterol every day if you want to, 3 meals a day, but if it's not the one could oxidize the LDL, then you will be fine. You won't have any indication or trigger of the development of atherosclerosis. So when we isolated the LDL, we looked at in the treated animals, and we looked into the control animals. We isolated and purified the LDL, and there we found that the oxidized LDL was the atherogenic. We had animals where we have the high LDL. The LDL is high in both, but we looked into oxidized versus unoxidized. We've seen that the high LDL, unoxidized LDL, didn't do nothing to the lining of the smooth muscles or the arteries. All right. So again, the LH and FSH with testosterone. This is another study where we combined testosterone with estradiol. We achieved a nice profile, estrogen, and we looked at the pituitary hormones in here, FSH and LH. Same thing in here. We looked at the serum estradiol by combining testosterone and estradiol. This is all straightforward. We're just looking at daily sustained level of steroids. We're not looking for peaks or pulsatile or looking at any other parameters within the capsules. Again, this is serum testosterone level plus estradiol. Again, the same thing, showing the sustained delivery and all of that. Then we attempted progesterone in overactimized animals. We've seen the same thing, proved that we should be able to do that. And then we measured the byproducts of the sustained delivery of testosterone. And interestingly speaking, we found that IGF-1 was elevated. IGF-1, this is the IGF-1, that's the replacement of the steroids the athletes they take now. When Dianabol or testosterone was banned, then the shift went into IGF-1. So the athletes start taking IGF-1, insulin-like growth factor 1. All right. So what we found out, we said, wait a minute in here. The testosterone, it's anabolic, and what exactly doing the job in terms of stimulating or hypertrophied the muscle and skeletal muscle and etc. We said, is directly the testosterone is doing this, or is a byproduct from testosterone? And then we found out when we gave sustained level of testosterone, we found automatically that the IGF-1 went up. So we looked at dose dependency in there. We used 5 nanograms, and we used high dose, 15 nanograms of 2 nanograms and 5 nanograms. Actually, we did 15 in another study. So 2 and 5 nanograms sustained levels. So what we've seen the IGF-1, highly stimulated due to the testosterone release. So this is the hallmark of this is the longest sustained delivery capsule we developed, where we went up to 350 days in sheep. Okay, that was a tedious project, and actually what we used in here, we used the more potent male hormone. We used the dihydrotestosterone, and we went for 350 days, and we bled those animals daily for 350 days. Okay, so basically we lived in the barn in there, but it's not really hard to go. We know 15, 20 sheep, usually it takes half an hour, 45 minutes with the help, we got a helper in there, you could bleed all the animals. All right, so that's showing, that was funded back then, by OTA, and that shows you the nice sustained delivery profiles for almost a year. All right, now again, we followed that. We looked into the IGF-1. That's a concern about cardiovascular disease. So that's, showing the correlation in there. Imagine if that's a sustained levels, that's using a tiny, minute amount of the drug released in circulation. Imagine if people taking tablets, 200-300 milligrams every day to boost their skeletal muscles, what would be the IGF-1? And that's, like I said, this IGF-1 is highly atherogenic. That could cause, major problem in the muscle of the heart. And this is showing you the correlation between the animals. See that? That's tabulating the release profile from each animal to get you an idea that it's the reproducibility in there of the, again, with serum testosterone in here, the one I showed you previously was DHT, and this is testosterone for almost a year, followed the same track. And then here you go, the pituitary response. The pituitary response, suppression almost to undetectable level. And as you see in there, see that? This is from the treated animals, experimental animals. The serum FSH, almost undetectable. All right? And then again, with testosterone low and high dose, you will see the increase in the IGF-1. Okay, now the challenge. The challenge, which is, I'm doing okay in time, Shai? We're doing okay. We're doing okay in time? All right, okay. Now, this is the challenge now, developing a dual release profile, estrogen and progesterone. What we use this strain of animals, so corridor strain of sheep. They've got they used significantly as a model for cardiovascular. So, and here we developed from all that experience and how, knowing the release profile for estrogen and progesterone and testosterone and DHT, we're able now to fabricate the capsule. That's what we need, the multi-layered ones, okay? And we followed the same engineering stuff, how to make the capsule I mentioned yesterday. We mix the oxides, we fire them at higher temperatures, and then we grind to get the exact particle sizes, and then we fire them again to get the mechanical strength that what we need to release the hormones, and then we sterilize them, and they were ready for implantations. So we follow the same format. We do all that process. It takes about a week to make a 1 capsule or 100 capsules. So you have to go through that process. That's 2 days in here, 1 day in here, 1 day in here. So it's about a week to make those capsules. All right, and then we implanted them subcutaneously under the skin. We attempted the first trial, we attempted close to 30 different capsules to see if we could get release profiles. But I'm not going to show you all of them. would be here all day to show you the profiles and the serum level of hormones from all of these. So we selected the ones that they're close enough to mimic the estrous cycle in sheep. So the idea is in here, like I said, we wanted to mimic the estrous cycle in sheep. The estrous cycle in sheep is about 14 days, and human is 28 days. So we wanted to mimic this. See that? We wanted to mimic this by releasing this. So we wanted to have a sustained level of estrogen, a little bit high, very low progesterone, and then we needed to have a spike, which is in the ovulatory phase, and then we needed a release of both of them in the second half of the cycle. In the sheep is the second 7 days, in the human the second 14 days in the luteal phase. So to develop this cycle, the main thing is the burst effect right in here. You have to have a spike of estrogen to end up with the enough level of LH and FSH to induce the ovulatory phase. All right? So that's the main thing in here. Like as you see it here in human, it goes the level 10, 15, 20 picograms per mil. And then in the spike in here, it goes to about 150 picograms for about 12 to 16, 18 hours, okay, of estrogen. That's in reproductive life in the female, all the way till the menopausal stage. So they experience that the spike of estrogen in the ovulatory phase, which is about 14 days. Now here, like I said, but you've got to watch the pituitary hormones in there. Okay, we've got to watch the LH and FSH. That's the key component in the implantation of the follicle. Okay, now here is from a previous we did for a sheep. We did an attempt, looked in a rat, small model, easy to work with, to see if we could do that. So we did a quick trial, a pilot study here, looked into overactomized rats. And we've seen that we were able to release the estrogen and progesterone profile. We did massive, histopathological evaluations. We looked at the changes in the vaginal tissue. We looked at changes in the uterus. We looked at all of these things. We saw that whatever released estrogen and progesterone combination was functional and induced, the cornified cells to be more active, and we've seen the mimics the ovulatory phase and also the growth in the follicle and the luteal phase. So very fast to do it in a small animals as opposed to dealing it with a sheep. So from there we said, well, we could move ahead and do and work with the sheep model. So here is the samples of the one we felt that they worked. The sheep, I selected the one we worked. This is a very, very tough capsule in there. So the capsule released here. Remember, these are all of these implanted like around May, like in the summer, and the estrogen and progesterone in the summer in the sheep, they're in non-breeding season after February. So all the controls, they will read 0. Estrogen and progesterone is 0. So here we are we're making the sheep cycling in the heart of the summer. Okay? They're cycling in non-breeding season. Okay. Now, here is what you see, and this is a close-up. This is a close-up capsule. We thought this is very interesting. We saw the release of estrogen and progesterone slightly high. And then we've seen a spike of estrogen. That's what we're looking for. That will induce the ovulatory phase. And then from there, we've seen a release of, we're able to get the progesterone and luteal phase, and we saw just a spike of estrogen. All right? That's for 29 days. That's another attempt in here for the same thing with looking at the pituitary hormones. So we've seen it really kicking, and another way, it's inducing some action in non-breeding season. So we've seen the LH level, spikes of LH levels, at 3rd days, at 11 days, and after close to 3 weeks. And then for the FSH levels, we've seen the level is kind of suppressed from the whatever released, progesterone released from the capsule. So we're seeing the progesterone, the FSH is controlled, and we've seen spikes of LH. So at that point in there with this capsule, we said, well, the pituitary, the brain is really responding. What's coming out from the capsules. Now, the next one in here, this is the ideal, what we felt that is the good one, and that's induced a cycle. So we ended up with one cycle in here, and where we have, you see the release of estrogen and progesterone at a low level, and then here you go, the spike, ovulatory phase, and then we try to maintain, level of estrogen and progesterone in the last 14 days. So this is induced the first cycle in the middle of the summer. Like I said, the other control animals, everything is zero right in here. There is nothing in there. Again, looking at LH and FSH, you see that the spike of LH, which is, and FSH, same thing, maintained or suppressed at the lower levels. Okay, so here is a close-up. We did a window, what we call it a window, looking at a burst effect in there for 180 minutes, bleeding like I mentioned earlier, every 15 minutes to get the blood, get the serum, spin it, and measure the hormones. And we've seen here a regression or suppression of the LH and FSH levels. Again, this is another one we felt is induced another cycle in here with much better, capsule, and a smaller actually capsule with less drugs in there, induced us to the cycle, estrogen and progesterone, and then a spike of estrogen, and then it went down, and a luteal phase, good level of progesterone. All right, again, looking at the pituitary response, suppression of LH and FSH. Again, the window, same thing, showing the LH and FSH windows, correlates with that. Again, serum, another model, which is induced the thing. However, even we didn't get the good spike of estrogen, but that was able to induce the activity of the ovulatory phase, which is actually the estrus here in the sheep. All right, they keep saying ovulatory, which is estrus. The sheep, they don't bleed, but they have the estrus activity, estrus, proestrus, diestrus, and etc. Okay, so we've seen an early estrus phenomenon here. Here is another one which is ready for the market, for inducing or having sheep cycling, throughout the year. And you see estrogen and progesterone, the spike of estrogen, and then good level of estrogen and progesterone response from the brain. LH and FSH, you see the spikes of LH, and then you will see the FSH level suppressed. When you look at the normal ones, I have it in another slide, I think it's coming. LH and FSH way off the curve, it's way high. All right, these are close up, windows just showing you, this is the 15-minute bleeding to affirm the cyclic activity and the pulsatile secretions of the animals. We'll look at the LH and FSH in here. This is another sample in there to show that we've seen a consistency, we've seen a suppression. You see, this is the control animals, high LH and FSH, and this is the treated animals. The LH and FSH goes down almost to undetectable levels. All right, so with this being said, that we were able to develop a capsule. It could induce the cyclic activities, and from there we went forward, with looking into different applications. Now we used, we had students use another project using a combination therapy, antioxidants and using antioxidants and other hormones for a treatment of different things we had one with the Alzheimer's, we had one with Parkinson's, and we had one project, dealt with multiple sclerosis. And so we looked into several of those applications where we employed antioxidant activities. All right. All right, so I'll explain all of this. So like I said, the conclusion from this, we developed a capsule that was capable of inducing estrous cycle in non-breeding season. This is the first report to show the dual release of estrogen and progesterone. and we said this is a device is ready to be employed for different applications. All right, and that's the type of sheep we use. I thank you for listening, and I don't know if I'm on time or if I have time for questions. Thank you.
Yeah. For anybody have questions? Yeah. Okay.
All right.
Yeah. Okay.
Was this driven by sort of demands from the market, from the farmers?
You mean the support? The support were funded by different organizations. We were supported by OREF. We had support by OTA. We had early. We had NSF funding through EBSCOR. We had multiple different. So, yeah. For the NSF mainly, they were interested in technology. National Science Foundation in the U.S.
And do you see any commercial sort of implications in terms of changing the breeding of sheep?
Commercially, yeah.
Like
Commercial.
veterinary applications.
Yeah. Well, is there anything in the market now?
Yeah.
Is that what you're saying?
Yeah.
No, none. It's not. We have an interest from a company for human use now, for orthopedic. They want to pick up that, but not for veterinarian use now. Right. Thank you.
Yeah, already.
Thank you.
Thank you again. Yeah, okay.